First, I would love to thank the MOH for inviting me. I'm really pleased to be here with my colleagues and friend and Saudi. So we'll start our discussion today, a debate about linezolid for staphylococcal bloodstream infection. Is it an option or not, I think. Okay. So the objectives for today's talk, we'll first bacteremia, and then we'll discuss some clinical evidence about the efficacy and safety of linezolid for staphylococci bacteremia. So before we start our debate, it's good to give you some context. Start with linezolid. It's a oxazolidone, broad spectrum gram-positive bacteria. VRE. In the US and the FDA, it is licensed for the treatment of complicated and uncomplicated skin and skin structure infections, as well as pneumonia, and also for the treatment of vancomycin-resistant enterococci infections. However, it's not licensed for the treatment of for bacteremia, bloodstream infections, and that will be the topic of our discussion today. And why do we care about the staphylococci bloodstream infections? Staphylococci or Staph aureus is a common colonizer of the human skin and nasal area, and it can cause breakthrough infections resulting in some complicated and uncomplicated infections. Staphylococci aureus bacteremia is, when untreated, can cause high mortality and morbidity burden. For uncomplicated cases of Staph aureus bacteremia, the treatment is usually a minimum of 2 weeks. And in cases of complicated and metastatic disease, the treatment actually can be extended to 4 to 6 weeks of antibiotics. Some predictor for good outcome is source control, duration of bacteremia, other comorbidities, as well as time to optimal antimicrobial therapy. So first, I'll start with being against the use of linezolid for bacteremia. And some of the points we'll discuss, and I'll explain each one in more details. The first argument would be that linezolid is a bacteriostatic agent. It has some adverse drug reactions that we want to avoid. It comes with some drug-drug interactions, and it's not licensed for more than 28 days. And then finally, I will discuss some evidence against the use of linezolid for Staph bacteremia. So why do we care about an agent to be bacteriostatic versus bactericidal? So bacteriostatics mean the agent will not kill the bacteria, but rather would prevent the growth of the bacteria. And this has become significant, in my view, as an against linezolid, is there is a recent paper as the duration of Staph bacteremia extends. And you can see from the graph here, as the duration of bacteremia increases beyond 3 days, the risk of mortality is significantly higher. And the argument would be, although it's not proven, the argument would be a bactericidal agent that kills the organism could potentially result in quicker time to clearance of the bacteria. And hence why we would use or prefer to use a bactericidal for Staph bacteremia. The second point, or the second argument against linezolid, is that it comes with a thrombocytopenia. And here I list this table from a meta-analysis of randomized controlled trials that compared linezolid to vancomycin. And you can see clearly from the last line, the total percentage of thrombocytopenia was more in linezolid compared to vancomycin, which vancomycin itself comes with a minimum risk of thrombocytopenia itself. So Staph bacteremia treatment is a minimum of 2 weeks, so the risk is higher. Also, it can result in treatment discontinuation. One paper actually documented 50% treatment discontinuation from using linezolid treatment. The good news, though, it's mostly reversible as we stop the treatment agents. The next point would be drug-drug interactions. Linezolid in itself is a weak monoamine oxidase antagonist, and as a class that comes with a lot of drug-drug interactions. Most serious one would be interacting with serotogenic agents and increase the risk of serotonin syndrome. And then I list some of the classes of medication, most commonly antidepressants, SSRIs, tricyclic antidepressant, and of course monoamine antagonist. And this is actually becomes more and more relevant today as the use of these agents is increasing. The diagnosis of psychiatric illness is increasing, as well as the use of these agents for other indications as well. So one study reported the risk of SSRI or serotonin syndrome with linezolid and other serotonin agents to be as low as only 0.1%. But this actually can be devastating and life-threatening. Next, I will discuss two studies actually showed some negative outcomes when linezolid is used for bacteremia. The first paper here by Usuri and colleagues is a single-center retrospective study that looked at linezolid versus daptomycin and vancomycin for MRSA bacteremia. Mostly were primary or catheter related. And their primary outcome was clinical cure, which didn't show any difference between the group, but they had one of their secondary outcome, which was all-cause mortality, and linezolid has a significantly high percentage of mortality, 40% compared to 19 with daptomycin and 9 with vancomycin. Actually, Wilcox and colleague, it's a multi-center that looked at linezolid for the treatment of skin and skin structure infections compared to vancomycin if it's MRSA or oxacillin if it's an MSSA. And then the primary outcome looked at microbiological outcome at test of cure. We didn't find any difference between the two groups. But actually, when you look at the secondary outcomes and the analysis, there's intention to treat mortality at day 84 of therapy, and there was an increased risk of mortality in the linezolid group. This actually led the FDA to issue a warning against the use of linezolid for treatment of catheter-related infections. And that's a very good reason why I would be against the use of linezolid for bacteremia. Now Dr. Khalid will try to tell you why he's with linezolid.
Assalamu alaikum. Good morning, everyone. I would like to thank the scientific and organizing committee for this wonderful conference. Thank you, Dr. Sarah, for the kind introduction, and Dr. Ahmad for discussing why you are. But let me now present to you why I think we should use linezolid. Okay, first of all, let's admit that linezolid have some advantages over vancomycin or the other parenteral therapy for MRSA. It's available orally. This is a big advantage. As Dr. Ahmad said, when we treat bacteremia, if it's uncomplicated, then we need at least 2 weeks. Many times it's complicated and we need 4 weeks or longer. So to keep patients on IV all these duration, it's not good for all patients. So it's an advantage to have something that we can use orally. Now, we need IV. I will not go over this debate, but anyway, linezolid is equivalent orally with the IV. The bioavailability is almost 100%. So don't worry about giving something oral for now. And when you talk about IV therapy, they are not the best, right? IV therapy, lot of issues, less convenient, and the catheter-related complication. So it's not that Linezolid is just less safe. We have issues with giving IV therapy for MRSA bacteremia. In addition, as you know, vancomycin, the first-line agent for MRSA bacteremia, it needs therapeutic drug monitoring. It becomes even more challenging as outpatients. One of the advantages of Linezolid is that generally it doesn't need therapeutic drug monitoring compared to vancomycin. So all of these are advantages. And Dr. Ahmad was biased. He presented only the data that showed Linezolid is bad. But we have data showing that Linezolid is fine, is as good as the standard therapy. So let's see. First of all, we have this first article published in 2005. And this is actually a pooled analysis of 5 RCTs. So it's close to a meta-analysis. And I only looked specifically because, when Linezolid was studied, it was studied in pneumonia, skin infections. But we have a subset of patients in those RCTs who had also secondary bacteremia. So if we took this subset with MRSA bacteremia, we have around 36 patients in Linezolid group and 37 patients in vancomycin group. As I said, 5 studies, MRSA bacteremia in the RCTs. Pneumonia was the source, by the way, in 40% of cases. As you know, some data showed that Linezolid may be better. It's debatable in case of pneumonia compared to vanco. If you look at the outcomes, no significant difference between the two groups in clinical cure. So 56% in Linezolid group, 46% in vancomycin group. And overall survival, almost the same, about 65%, no difference. So based on data from RCTs, we didn't find a difference here. Unfortunately, we don't have an RCT simply Linezolid versus vanco for MRSA bacteremia. But anyway, when you talk about bacteremia, most of the time for any agents, we will not find RCTs. It's very rare to find an RCT with bacteremia. The sample size is one of the biggest issue. But there are some observational studies by now, so let's present those. So the first one is published in 2012 by Park et al. This is a single-center prospective cohort study, and they compared Linezolid and they combined it with carbapenem in half of patients, 38 patients versus glycopeptide in 52 patients. Now, it's important to note that all these patients had persistent MRSA bacteremia. Okay? So let's see if Linezolid was good in those patients. They needed salvage therapy because of persistent bacteremia. Something to note about the differences between the two groups. If you look at the Linezolid group, they had longer duration of persistent bacteremia. So 16 days versus 10 days. Also, they had higher rate of infection acquired in ICU. So 33% versus 15%. This is important because it could affect the outcomes, especially. And as expected, if you look at the early microbiological response, no significant difference statistically, but numerically lower microbiological response in Linezolid group, and longer duration until culture conversion after 7 days. But again, if you look at the baseline, they already had longer persistent bacteremia. So this doesn't mean Linezolid is worse. Plus, what's more important is what? The clinical outcomes, not the microbiological outcomes. Treatment success, no difference, about 70% in both groups. And 30-day mortality, 11% versus 25%. So numerically, it was in favor of Linezolid group. but it was not statistically significant because the p-value is 0.08. But at least Linezolid here didn't increase mortality. Was it the reason for lower mortality? It's difficult to say that in observational studies. Even after logistic regression and propensity score matching, the same outcome, no difference. The next study was published just 4 years ago by Jorgensen et al. This was a single center, retrospective propensity score match study. Now in this study, the first group was not only Linezolid alone, it was oral outpatient antibiotic therapy, 70 patients. 50% of them received Linezolid. So they are looking more at oral versus IV more than Linezolid specifically compared to IV, either vanco or dapto mostly. Now, those patients needed to have clearance prior to hospital discharge. And about half of them have primary or catheter-related bacteremia, and 2/3 had complicated bloodstream infection. If you look at the outcome, 90-day clinical failure, no difference between the two groups, numerically in favor of Linezolid, but didn't achieve statistical significance because the hazard ratio crossed 1. And if you look at the secondary outcomes, lower adjusted hazard ratio with Linezolid, 0.6 in the 90-day hospital readmission. So again, at least Linezolid was not worse. And the last study was published just last year by Yeager et al., another retrospective study. Now, this study did something different. They compared oral step down versus continuing IV therapy. The propensity score matched patients were 54 in both groups. And they required, again, clearance of MRSA culture prior to hospital discharge. Unfortunately, the two groups were not balanced, which is expected in retrospective studies. So more patients in the IV group had complicated bacteremia, 70% versus 40%, and more metastatic foci, 45% versus 20%. And they received longer duration of therapy, 45 days versus 22 days. So in this study, without propensity score matching, you will not trust the result at all. But with propensity score matching, it reduces the impact of confounding factors. Now, if you look at 90-day infection-related readmission, no significant difference. In the matched patients, 17 versus 30. All-cause mortality 90 days was 4 versus 6. As you can see, the percentage is low. They were not at high risk of mortality because they were outpatients. They required clearance of bacteremia. No difference in length of stay. And no difference in side effects, by the way. Even though the median duration in Linezolid was 22 days, there was no difference in the overall side effects. But if you look at the adverse events requiring rehospitalization, it was significantly lower in the Linezolid group. 2% versus 12%, statistically significant. These are the studies, not the best studies, mostly observational or pooled analysis from RCTs. Frequently it showed Linezolid might be better or at least not worse. Now for the rebuttal. I already presented the data why Linezolid can be an option. We are not saying it's an option for all cases. I'm not saying replace vanco for all patients and use Linezolid. No, but it can be an option. Unlike what is done now in many hospitals, they never give Linezolid for MRSA bacteremia. But what about what Dr. Ahmad said? He presented valid points, some issues with Linezolid. So now we're going to discuss those points. First of all, the side effects. A lot of people say, no Linezolid for bacteremia. Why? Because of side effects. This is important to consider, important to counsel, important to monitor, but it's not a contraindication. You can still try Linezolid in those patients. Not all patients develop those side effects. Plus, patient with uncomplicated bacteremia can be treated with just 2 weeks. Most of the side effects appear after 2 weeks, so you still can use it, or you can start with IV therapy and then switch to complete the remaining duration with Linezolid. So it's not a contraindication. And you can monitor these side effects, especially the most important one, thrombocytopenia. You can monitor the platelet. It's not difficult. If the patient develops severe thrombocytopenia, then you can change. And it's reversible, as Dr. Ahmad mentioned. IV therapy is not without complications. You know, we mentioned the catheter-related complication. It's less convenient. Some hospitals don't have OPAT, so they keep patient inside the hospital for a long time. And with regard to the drug-drug interaction, this is a whole debate. But as Dr. Ahmad said, Linezolid is a weak MAO inhibitor, unlike the old antidepressants. So the interaction is debatable. It's not an absolute contraindication. You will see many hospitals, and some of them publish their data, showing that maybe it can be used in some cases, especially if someone is not on high doses, not on strong serotonergic agent or multiple agents. It's not an absolute contraindication. Plus, especially in our community in Saudi Arabia, the majority of patients are not on serotonergic agent. So this drug interaction doesn't affect the majority of patients. The other point, a lot of people mention it. Honestly, at pharmacy school, most of us teach it, static, and it seems like it's less effective, but there is no proof at all. Static matters clinically. No proof. We have this fear, but many consider it a myth. So until now, we don't have evidence. Static is bad. We have more important issues. The dose, the pharmacokinetic, the drug itself. These are much more important than static cider. And by the way, a published systematic review, very interesting, supervised by Brad Spielberg. Many of you know them from Twitter. He's a very famous ID physician. And what they did is that they compared all the randomized controlled trials that compared bacteriostatic versus bactericidal. What do you expect? More death with static? No. They included how many studies? 56 studies. 56 RCTs. What are the results? No difference in 49 of them. Almost all except 7. No difference at all. What about the remaining 7? In 6 out of 7, the static was more effective. In 6 out of 7, the static was more effective. So it's not the most important thing, static. We have other more important stuff. The dose, the pharmacokinetic. Okay, we have just one RCT that showed Cidal was more effective. Why is that? In that study, they compared tigecycline, this was the static agent, versus imipenem for VAP. And they found higher mortality with tigecycline. And this is not likely due to being static, but it's most likely due to maybe the dose. That's why this dose is no longer recommended generally for pneumonia. The tissue penetration is not good with tigecycline. Now the recommended dose is higher than the approved dose, double the dose. And when they published a small RCT about this, they didn't find a difference. So no single study using a good dose ever showed static to be less effective.
Dr. Khalid.
Since Dr. Ahmad actually agrees with me, now we are in the rebuttal, he's gonna continue and finish the rebuttal why we think Linezolid should be at least an option in MRSA bacteremia.
Thank you, Dr. Khalid. So Dr. Khalid did a great job. He convinced me to change my mind. And I will reconsider the evidence I posted earlier. So the first trial, the usury trial that we showed, had an all-cause mortality higher in the Linezolid group. It actually had a lot of limitations. It's first single center retrospective. It's unbalanced, only 15 patients in linezolid compared to 53 and 54 on daptomycin and vancomycin respectively. And it has some other limitations as well, that linezolid was only started by ID physicians, which give you a suggestion it could be more sicker patients. And with all the evidence Dr. Khalid actually presented before I come up, it's actually makes me more comfortable to kind of overlook this study due to its limitations. The second study, which is actually a big one that actually showed increased intention to treat mortality in the intention to treat group on day 84 of linezolid, actually had also its own limitations. When they looked at these intention to treat group, they found that the increased mortality was mainly driven by those with culture negative, they didn't have any positive culture, or they had a mixed gram-positive and gram-negative culture. And when they looked at the only gram-positive, which is the modified intention to treat group, they didn't find any difference between the two groups. So a way to look at it, if you want to be extremely conservative, you can suggest we will avoid using linezolid empirically for patients, but if you have a culture positive and you're positive it's a gram-positive infection, linezolid, as shown by Dr. Khalid, can be a good option for certain infections. So just to summarize, unlike what we thought before, there is good volume of evidence to suggest linezolid can be a reasonable option for the treatment of MRSA and Staph aureus bacteremia in general, particularly in uncomplicated cases or as a step-down oral therapy. Although more high-quality RCTs would be required to confirm the efficacy, the exact efficacy of linezolid for the treatment of Staph bacteremia and the ideal target population in which linezolid can be used for. With this, I think we conclude, and we can have more questions or comment in the panel discussion. Thank you.